I invite Dr. Shefali Sardana to talk about the papers we are discussing.
So very good afternoon to all of you. So 7 papers in 10 minutes. I don't know how to justify that, but we'll be discussing Niagara, EV-303, IMVigor011, PSMAADDITION, AMPLITUDE, CAPITELLO, and KN64. 564, sorry. Okay, perfect. So I have purposefully put only one slide for it. So Niagara, very important. So it is a phase 3 RCT, perioperative Durva with chemo in MIBC. So unmet need was there because 50% would have a recurrence. So we will have some regimen which will show the good results. So integrates immuno in curative attempt. That was the important point. And neoadjuvant GEMSIS, the important point here to consider is they have taken the people with the EGFR of 40 to 60 also, where we conventionally think cisplatin is not the choice. They have done a modification that they use 35 milligram per meter square on day 1 and day 8, instead of conventional 70 milligram per meter square on day 1. And primary endpoint was EFS and PCR, secondary endpoint was OF. And we know 2 adjuvant trials of ICI have showed DFS advantage. So is it the right time to move it to the neoadjuvant or a perioperative setting? Key points were, like I mentioned, the creatinine clearance was one thing which they addressed in 40 to 60 with cis important component as compared to carbo. And adjuvant therapy, they allowed it to start between 42 to 120 days. So 120 days was the crux where they can start adjuvant, actually the people who did not recover or who had other limitations in recovery from surgery. So PDL1 expression was defined as TCIC 25% algorithm. That means the tumor area 25% at least would show the immune cell infiltration. And the results are here. So there were 28% who were Asians. 85% was pure TCC histology. There were 15% of other squamous and other histologies also. 19% had GFR between 40 to 60. Tumor PDL1 was high in 73 and low in 27%. And however, the PCR was numerically there, but it was not statistically significant. So you cannot vouch on PCR in using this regimen. The median duration of follow-up was 42 months. And estimated EFS at 24 months was 67 versus 59%. Hazard ratio was 0.68. And estimated OS at 24 months was 82% versus 75%. Again, hazard ratio of 0.75. So Durva with GEMSIS in peri-op setting significantly improved EFS and OS. There was a numerical increase in PCR. Now coming to EV-303. So that was cisplatin eligible. This is cisplatin ineligible. And the important point to note here is they allowed cisplatin eligible also, but who declined cisplatin usage. So people who did not want to use cisplatin, they allowed in this trial. So we have a choice because one important point which I wanted to address here is apart for these key points that again 85% was urothelial histology. They allowed PS0 to 2. T2 or node positive were included, and the main benefit again was seen in the heavy nodal burden or beyond T2. So T2 alone, T2N0 was not the subset where the significant advantage was seen. And important point here is the timeline of the study design development. So they initiated with 2 arms only, that is Pembro with the radical cystectomy versus surgery alone. In 2020, the 3rd arm was added, that is EV plus Pembro with the surgery, 1:1:1 randomization. 22, they expanded to include participants who are eligible but not want cisplatin as a chemotherapy arm. 2022, they removed that Pembro with the surgery arm because they saw that benefit was more in addition of, say, EV. And important point apart in this busy slide is the PCR you can see is 57%. This is the first time where this kind of PCR in MIBC is seen. So can we extrapolate it to the cisplatin eligible group? Though it was 20% representation is the food for thought. So I'll skip that slide. So IMVigor011. So phase 3 RCT, MIBC, where again we know that not every patient receives NACT and 50% of patients will have recurrence again. So this trial was designed to basically evaluate the efficacy and safety of adjuvant atezo based on the ctDNA analysis. We know that ctDNA has been a component in many organs to decide for the therapies, but is it the right time in MIBC also? So the key points was, again, primary endpoint was investigator assessed DFS. Secondary endpoint was all these. Out of 761 enrolled, 250 were tested positive for ctDNA, and they were then randomized 2:1 to atezo versus placebo. 129 who tested positive did not undergo randomization due to various reasons. 357 were persistently ctDNA negative. Now, the important point which I want to mention apart for the median follow-up and other thing is, there was spontaneous clearance of ctDNA in the patients who were there in the randomized thing, and also the patients in the ctDNA negative group, basically, who were put on monitoring. Some of them also relapsed. Now, how do we put that data into a conclusion is the food for thought here. So are we ready to adopt this approach in clinical practice is one question. How safe and evidence-based is de-escalation? We don't know. Because the people in ctDNA negative group relapsing, what is the answer for them? And is this follow-up period enough to make a decision? Or is it like other MRD trial where no OS will come ever? And it's the DFS we need to take an answer on. So coming to the next trial is PSMAADDITION. It is basically the first phase 3 trial of PSMA lutetium therapy along with ADT and androgen receptor pathway inhibitors in the PSMA positive HSPC. We know lutetium has a place in CRPC. People are moving it to the first detected CRPC also, and in the later lines too we were utilizing. But is there a place in HSPC also? So I will not go into the eligibility things. Here, I don't know whether it is visible. So it was a ESMO 2025 presentation of the second interim radiological PFS and first interim OS. 1,144 patients were randomized, and crossover was observed in 16% in the control arm also. Till date, whatever data is available, so study met the primary endpoint. Radiological PFS significantly prolonged in the lutetium arm with hazard ratio of 0.72. Radiological PFS benefit was consistent across all the subgroup, be it the visceral mets, which were PSMA avid, or the bony metastasis. OS data shows trends, but data is still immature. ORR is 85% versus 81%. Complete responders were 57% versus 42%. And majority of the patients were able to complete at least 4 cycles of lutetium. So when we use lutetium, we have a concern of cytopenias happening. So I have personally used it in my clinical practice also. Till date, no significant grade 3 or grade 4 cytopenias I have ever seen. So this is the data which is available in the first line now with HSPC. And coming to AMPLITUDE now. So AMPLITUDE is basically niraparib and abiraterone to HRR deficient metastatic CSPC. We know we have data in CRPC available, but it is important to see whether it has, So we know that CRPC data is available, but is it the right time to use it in CSPC? So this trial had a 1:1 randomization. So the results were first met in the BRCA group, which is understandable. That is the more common pathway. But they could see in control arm, as compared to control arm, they could see the benefits in other HRR pathway genes also. And there were 14 adverse events related deaths in the experimental as compared to 7 in the control arm. So that is also a significant figure. 56% had BRCA, 1 and 2, and other were conclusively the other HRR pathway genes. Only key point I could see was that drug-drug interaction was observed between niraparib and apalutamide, so they allowed mostly abiraterone in this pathway. So we should be cautious while we combined apalutamide with the PARP inhibitors, though all 3 were allowed, but later on they included this. CAPITELLO, I'll go on to the last one. So CAPITELLO, basically I'll mention capivasertib in PTEN deficient patient, because PI3K pathway is activated. So the only challenge which I could see and derive is median radiological PFS was comparatively low in control arm despite a high-risk population as compared to which was there in LATITUDE. Efficacy was seen, however, intensification with triplet is still unknown. Whether we combine capivasertib with a triplet, which is a standard of care, we don't know. Because control arm here was ADT plus ARPI in a high-risk group. Third is, the challenge is how to test PTEN. So because in breast, we have, say, liquid biopsy picking out more. But here, they use standardized IHC, and the cutoff was 90% staining. So we don't know which method is the best way to go for. And that is how I'll conclude. Sir, I have justified 10 minutes. Thank you.
Long marathon and justified quite well, Shefali. And with that, Shefali, since you have read all the papers, can I request you also to be one of the panelists here? Please come here. Before I invite moderator, I must say this, that I'm a big fan of Senthil Rajappa. Whether, whatever way he says, and I think I have requested him specifically for today, at least, whenever he think that any discussion is going tangential or he wants to comment, Senthil, please, say your thing. And with that, I wanted also, as the opening session, Dr. Senthil to be one of the panelists. Dr. Senthil, please come. With that, I invite our opening batsman moderator, Ghanashyam Dada. Dr. Ghanashyam Biswas has been the opening batsman in almost every OBTO. Ghanashyam is going to moderate the first session, that is Niagara, EV-303 and IMVigor011. So I must say this, all the papers which I had selected, again, I had reached out to Senthil and Tarini Sahoo for their opinion, and all these papers which are there is amongst the joint discussion amongst three of us. So I thank for them. Ghanashyam, please come here. I will invite the panelist. Dr. Priya Tiwari is 16 minutes away in the traffic. Dr. Rishabh Kothari. Is Dr. Vivek Agarwal here? Vivek is not here. Okay. Dr. Rajkumar Ramaswamy. Dr. Sushant Mittal is also on the way. Dr. Satyankar Gupta. Yes. Dr. Soumya Surat Panda. Rishabh, I have said. 1, 2, 3, 4. So you have 6 panelists. Ghanashyam, please take over.
So good afternoon. Thank you, Purvisha. Thank you, Amish. So I'll start with a MIBC case, Mr. SR. He is a 70-year male businessman, so diabetes and hypertensive controlled. So COPD, a chronic smoker and a chronic smokeless tobacco. So discontinued his habit since the diagnosis of this disease. In August 2025, patient presented the repeated episodes of hematuria, pain, hypogastrium, occasional pain urethra, and undergoes a USG KUB followed by CCT KUB with a CT urogram. So this was the report. You can see on the, in the USG mass in the urinary bladder, which is 3.3 centimeter, prostatomegaly, solid lesion of 2.5 centimeter abutting the posterior wall of the urinary bladder, and right distal ureter, enlarged right inguinal lymph node with a preserved fat, so thinking it to be a benign one. And if you see, as there was COPD changes. So apparently T2N0 carcinoma urinary bladder. Dr. Shefali, when was the last female with a urinary bladder you have seen? Do you remember?
So, I mean, it's been 5-6 months, but SNA urinary bladder nahi hai female mein. Right. So
it is rare.
So it's lesser, yes.
So we talk about when was the last male to be seen with a gallbladder cancer. The similar is the urinary bladder is the last.
Sure, sir. Yeah.
So first thing, when you deal with like this disease, it is a teamwork is essential. A multidisciplinary approach should be there. So this is the MIBC team. So Dr. Satyankar, so do you have a team for treating those mentioned here in your center?
Yes, largely we have all of those, except for molecular biologist. We have all of those.
Dr. Ramaswamy?
We have the same kind of multidisciplinary, but majority of the patients will end up with the urology OPD upfront rather than any of the oncologists.
I know
That's
Dr. Senthil, Dr. Somya all have. So now in our case, a subsequent approach, patient undergoes a TURBT in a local hospital, that is Bagchi Hospital, and you can see the histopathology. Invasive urothelial cancer, high grade, involves musculus propria and deep muscle. So IC was GATA positive, muscle invasive bladder cancer. So again, AGCC 9th, stage 2, so T2B N0M0. So this is what the AGCC 9 looks like. So MIBC, if you look T2A, inner half in muscle involvement, and T2B is the outer half. So now in our case, so subsequently he moves from Odisha to the cancer journey to Kokilaben. So where a PET scan was done, so it was the same what was picked up in a CT scan. So now we need to know the facts to make a well-informed decision. So he has a ECOG performance status of 1, since it is a geriatric patient. So G8 score was 15, no significant peripheral sensory neuropathy, creatinine clearance of 87 ml per minute. Echo you can see fairly normal, audiometry bilateral, mild sensory neural hearing loss. So Dr. Somya, so what are the treatment options for this patient?
Yeah, so since this patient is otherwise Galsky is means not showing any comorbidities that will restrict him of cisplatin, so probably a neoadjuvant approach of GemCis will be correct one. So whether to add Durva to that or not will depend on discussion with the patient.
So Dr. Rishabh, now so these are options I mentioned, so these are possible. So do you want to omit, do you want to add something to this? So this is last 4 decades what is happening in the bladder cancer. So from none to many now. So I've included IMVigor011 also, Niagara also, and EV-303.
So as of now, I think neoadjuvant chemo with perioperative IO seems to be best option for him. Soon we will have EV pembro in cisplatin eligible as per press release. That is a separate story. But as of now, this would be a appropriate option for him.
So Dr. Senthil, so are all these valid options? So 1, 2, 3, 4, 7 options. So you'll have one or the other patient in your clinic who will be put to any of this.
Correct. I would be very discouraged or hesitant to offer option number 2. That means RC and then adjuvant chemotherapy.
So this still happens in a tier 2 city
I
where
agree.
God
Since you
operates.
asked me, are all these options, I would say that that's not a great thing to do, but all the others are absolutely fine to do.
So can I add one point here?
Please.
So last slide, sir, last slide, if you can please. So you have written IMVigor011 as an option, but we have not written nivolumab as an option. So
Option is there, no? Adjuvant IO.
I thought only IMVigor011
No,
you are
so
considering
IO and
that
so
way.
Nivo, Pembro, both are, even
Okay.
Atijo, all are there.
All right, yeah.
All situations.
So because we don't have answer to whether which one would be better approach. Nivo data also showed impressive result as a adjuvant IO, not based on ctDNA, not based on anything, just the high risk recurrence. So we don't know whether perioperative versus adjuvant IO, what answer do we have? So that is
So
what
at
I
this
would
time,
also
we
place.
have only DFS benefit. Right.
So the long term is still available. I
Right.
think OS trends are there, but
So
I don't know
no
about the
OS
long term
benefit
data
with-
I'm not aware of.
So Dr. Senthil, now yesterday, today, so we'll remain with radical cystectomy. So is there tomorrow, so radical cystectomy might get omitted? We are seeing a pathological response of 60 plus.
So one is the multidisciplinary, decision that one takes. The second, I think much more important is what is this patient ready for? Because he's a 70-year-old, he's got multiple comorbidities, his lung is not so great, right? You might say that this, geriatric assessment seems to be good, but that's only one part of the story. So my decision would entirely depend upon first, is this guy ready for cystectomy or not? That's the first question. I think for me, bladder cancer approach is becoming very similar to rectal cancer approach, right? So the first question I'd like to ask him.
So that's why I wrote, so probably
Assuming,
tomorrow.
correct,
Yeah.
correct. Assuming that he's got all the, wherewithal to do whatever he likes to do. So that's the first question I'd like to ask him is, are you willing to have a cystectomy done? Assuming that the surgeon says he can do one. The second question I'd like to ask him is, are you willing to take chemotherapy or not? Right? So if you say, I want to, keep my bladder, I'm ready to take chemo, then for me, Niagara is probably the best approach with the approvals as of today. You can always debate saying EV-Pembro is also an approach because it gives you a 55% pathological complete response. But assuming that that's not available for the time being, if you want to save your bladder, I think a chemo plus IO approach is what is most likely to get to that bladder preservation, so that you have a cystoscopy done after 4 cycles or whatever number you like, get an MRI done, get a PET CT done, get a ctDNA done, get the urine DNA done, and all good to go, right? So I think it has to be a nuanced approach. It's not 4 options and then which is what you want to tick, because I think we are seeing these kinds of patients who want to pick and choose, I don't want this, I want this, because all these options are valid options and there's no cross comparison between any of those options. If you can wait till 5 o'clock, I'll try to give you my ideas on what all of these are. But, I think it's a much more nuanced decision than just data. I think that's the point I'm trying to make.
So there is a quiz question. So any response pathological CR in a bladder's MIBC beyond 55, beyond what EV-303? So I'll answer in next minute. So anybody in the panel also? So I'll come to that. Yeah, Chirag sir.
So I was saying, if you want to save the bladder, the neoadjuvant part of Niagara is probably the best available approach as of today to get you to that point. Patient says, I don't want a cystectomy, chemo IO, reassess, see what the residue is, and then decide. That's what I was saying. I didn't say that, you should do that.
That requires a cystectomy to be performed. Otherwise, if we give radiation to the patient, it can be given, but that's not having enough evidence.
So I think a lot of what we are, so can you say IMVigor is better than Niagara? Can you say Checkmate 274 is inferior to Niagara? We can't. So that's what I think the theme started very well. We don't have direct comparisons. So we have to tell patients, these are the available options. If you want to get to this point, then you have to go through all of this.
Right. The only argument was to avoid
We have, sorry to interrupt you, Chirag. We have enough patients after 4 cycles of neoadjuvant who will say, I don't want a cystectomy.
Yeah, I agree. Yeah.
So then, will you say this is a non-standard approach? I won't say this is a non-standard approach. Instead of that, why don't you give the choice to the patient rather than saying, this is non-standard, I can't do it. We have enough patients. If good quality radiotherapy is there, please, that's very important. For bladder radiotherapy, you can't fire around, like you would usually do.
Right. So
but if it's good quality, sorry,
No,
I'll stop. If it's good quality
that.
radiotherapy, then I think that's an option that T2N0, look at that. I can always argue that Niagara is overkill for somebody with T2N0,
Right.
especially if it's T2A.
So
I would say just have cystectomy. Yeah. You probably don't need any further treatment at all.
Fine. In that case, why not CTRT upfront, bladder preservation?
Absolutely. That's why I said you need to.
So Chirag sir, I put that slide on.
So that's why.
So these are options. These are CTRT options because as I started. So there are patients who will still be on any of these. So now chemotherapy choices. So Soumya. So what are the chemotherapy choices? So GC versus MVAC versus DD-MVAC. So anybody superior, though we practice as GC. So any place for this?
Yeah, so mostly there is a data from the Biswas trial that DD-MVAC is better than GC, but 40% could not complete the DD-MVAC protocol. So GC is the one which most of us use.
So yes, so GC versus DD-MVAC and other choices can be MVAC and CMV. So from this you can see that GC is better tolerated if you compare GC and MVAC. So if you compare DD-MVAC versus MVAC, so DD-MVAC is superior. So this is the best probably have, and this was from the Biswas trial. And now, so neoadjuvant DD-MVAC was associated with significantly longer PFS and TTP compared to GC and was considered the new standard of care. So if you see the meta-analysis also says that it also pointed greater benefit for MVAC versus GC. So the crux of urinary bladder treatment, Dr. Rishabh. So So the same thing applies for any cisplatin eligible, like we are talking about head and neck cancer. So there's a Galsky criteria and there's a Gupta criteria.
So the rightmost one for me is something where we not giving cisplatin. As in Niagara trial, the 40 to 60 is something. As such, we were practicing split dose of cisplatin and trying to squeeze cisplatin wherever it was possible. So I think we have to be a bit broader in selecting. We try to give platinum whenever possible.
So if there are 100 patients of MIBC, so 50% goes out that they are not eligible for cisplatin. And 50% of those who are cisplatin eligible and 50% of them don't accept that treatment. So ultimately, it boils down to 1 out of 4. So the existing unmet medical needs in MIBC is 50%, as Shefali said, experience recurrence on progression following radical cystectomy within 5 years. So absolute benefit with the chemotherapy has been 5 to 8%. Restricted patient population eligible for ICA and those approved in the adjuvant setting, Pembro and Nivo. So there was no statistical significance for OS. So any biomarkers for Dr. Satyankar, so for MIBC?
I think PDL1 has not been very consistent across trials, but ctDNA has shown, newer insights.
Dr. Ramaswamy?
No, I think right now that we don't have a great biomarker.
So any
except
takers for HER2 positivity? So we do it in for a metastatic? Dr. Senthil, Soumya, Shefali?
Hardly any HER2 I've seen in MIBC, in urothelial.
So this is a food for thought. So you can do a PDL1, you can do a HER2 new and ctDNA, and that brings us to that. If you see, the last one is EV-303 with a 55%. And if you are doing a neoadjuvant in a HER2 positive, it is 64%. So that was the quiz answer. So 64% HER2 positive. So from moving from chemotherapy, GC to DD IMVAG to Niagara, and then EV-303, and then so to a HER2-based treatment. So 64%. So probably this is food for thought for bladder preservation. So endpoints for a neoadjuvant chemotherapy or a neoadjuvant IO chemotherapy. So Priya is in, so Soumya, so what are the endpoints for neoadjuvant chemotherapy or neoadjuvant IO chemotherapy?
So neoadjuvant chemotherapy has to be there. So the endpoints. Okay. So in most of the trials have taken primary endpoint of EFS and OS. So PCR has not been very consistently seen in the Niagara. It was not positive, but it was positive in the EV Pembro trial. It was positive. When it comes to PCR, EV Pembro looks better on the paper than Niagara.
So right. So our
Sir,
patient,
I think the question in MIBC is basically how can we have a complete pathological response. So that is one important set in perioperative or NACT setting. Apart for EFS, OS may take many, many years to come. I don't know how comfortable we are putting a OS as a criteria for, though it should be the standard one, what we are looking for.
Why do you want PAT-CR? What data says that anyhow I have to get PAT-CR, patient will live longer? We don't have
We
that
don't
data.
have, sir. Probably
So
EV-303.
in bladder, my intent will not be just to have PAT-CR.
Sir, the only question where PAT-CR in my understanding would matter with a limited knowledge, like Senthil sir told, that if patient refuses to have a radical surgery after 4 cycle, if you have, say, radiological CR and you do the biopsy and say, okay, it's a kind of sort of surrogate for PAT-CR, would that matter in the long term?
I don't
we
have enough
answer.
data to say that.
So
That is what I would
agree.
say.
So mostly it will move to ctDNA. So that what to clear. So PCR is not an ideal biomarker. So ctDNA looks as of now very strong.
So ctDNA, the challenge would be the serial values. It will not be a one standard value. So if PAT-CR can give you some answer and not the serial every time, I don't know. I agree with you.
so Shefali only some answer now, not full answer.
Sir, some answer. See, sir, PAT-CR. Yeah.
So now, so coming back to my patient, so that was so the patient received Niagara with Dr. Uma Dangi, and then he undergoes, I'm saying that he undergoes surgery by Dr. Yuvraj. So, and now, so how do you give cisplatin here, day 1 and day 108? Because, yeah, and again, Shefali said, so patients who had less than 60, that is 40 to 60 of GFR, So you can give a split cisplatin, that was 35-35. And now, so Niagara study we have seen. So Rushabh, you can see the dual primary endpoint of EFS and PCR. So now, so when do you say the trial is positive? So the both these endpoints, the primary endpoints should be positive, or either of these is positive?
No, sir. So based on their statistical plan,
Yes
so I
or
think
no
there was
answer?
alpha splitting here. So it is okay if either of it is positive.
Right. So study considered positive if either of the dual primary endpoints were met. So we know the Niagara background now. So perioperative immune checkpoint inhibitors could improve long-term clinical outcomes by priming anti-tumor immunity before surgery, and we are seeing that for head and neck cancer also, keynote 689, eradicating micrometastatic disease after surgery, and perioperative, this was a phase 2 of perioperative durvalumab showed safe and efficacious. So Niagara is the first global phase 3 trial to study, to evaluate a perioperative immune checkpoint inhibitor, durvalumab, combined with a neoadjuvant approach. So any patient which is best suited, Dr. Satyankar, for a Niagara, and this is from the trial. So this can be a small cohort also.
You know, obviously cisplatin eligible, MIBC, good performance status, T2 less than or T2 and above, both. No matter PDL1 doesn't matter much in this trial, and you know, classical urothelial histology with variants also included.
Shefali,
Any one of
you
those.
presented. So cisplatin eligible is a must.
Yes,
So,
sir. So I think, like sir said, T2AN0 or T2N0, no benefit was
so
remarkable.
more than T2N0.
Yeah, so it is T3, T4 or node positive.
And that's why I mentioned significant population, because
Yeah.
female versus male itself is a rare.
Yes, sir.
You see with other histology, normally
And
they does bad. So yeah.
Almost 89% was urothelial. So that is the hallmark to go
So
for.
that was deduced from this one. So event-free survival and OS. So both, in terms of hazards, they are showing better. So now coming back to the patient, so completed 3 cycles, a PET done, partial response, completed 4th cycle, and then undergoes cystectomy. So this was the PET report. And now, so post 4 cycles of Niagara and on surgery, so the pathological complete response. So Dr. Priya, so now what will be your adjuvant plan?
Sir, I'll just continue. The chemo is required here, so just immuno will be continued.
So how many cycles?
And I think 9 cycles in the trial now. So
8 cycles.
8 cycles. Sir,
I
now,
don't know
but
why Uma also wrote 9 cycles, but
yes,
this is
yes,
8
8
cycles.
now, so, but I think these are the cases where in future now we are moving towards ctDNA.
That may be a reason.
That in future we are now moving towards ctDNA, that if these are the groups of the patient where ctDNA in future, maybe you can just keep these patients under follow-up. Observation need not give anything in the future. That is how it's going to be. But as of now, this is what it is.
Yeah, so numerically, so you can see a pathological of 10% around difference. So luckily our patient fell into that category where attained a pathological CR. So plan for adjuvant durvalumab 8 cycles. So if you look at the toxicity, so grade 3 anemia requiring 3 units of blood transfusion, received IV iron also. Persistent grade 2 anemia may be related to chemotherapy. At present, grade 1 fatigue, clinically stable, ileal conduit functioning properly. So these are the event-free survival, and by this time we know that. So early separation is there. And so Soumya, so look, if you look at the Vesper and the Niagara, so chemotherapy versus chemotherapy immunotherapy. So if you see, so more patients in 60% of the patients were more than T2. So probably more high-risk patients were put into Niagara.
Yeah, but in Vesper, if you look at the completing new adjuvant, they were very less. 58% could complete the new adjuvant, so
Right.
around 40% could not complete that. But in this one, 85% could complete that.
Right. So these are toxicities have not. So now the same patient comes to us post radical cystectomy, what Dr. Senthil was saying, no? So these are patient come. So no new adjuvant, but this is a P-T3N0, PDL1 is high. And now look at the patient's, the G8 is now 12, creatinine clearance remains same. So so what will be the treatment? Rishabh?
So to part to it, we can do CTDN at this point of time and decide on adjuvant. I would generally try to give adjuvant chemotherapy also to this patient if ctDNA and ctDNA based treatment is not feasible.
So Priya?
So I agree completely. Actually, in the current scenario, we would have done like adjuvant chemotherapy followed by immunotherapy. But now you also have in a subset of patients just adjuvant immunotherapy. You also have now ctDNA data in this particular setting, and you can just do a ctDNA, irrespective of the stage of the disease. If the ctDNA is negative.
So I just wanted to, and Senthil can correct me if I'm wrong. We are talking so much about ctDNA in bladder. You know, IMVigor011, radical cystectomy specimen was taken. The tumor-informed ctDNA was planned, and the Natera was the one which did that. You can't just send, it was not a random ctDNA, Senthil, if I'm not wrong. So tumor-informed ctDNA is, I don't think I have seen any lab in India which is making tumor-informed ctDNA.
Agreed, sir.
So in absence of that, should we rely on ctDNA for any of these decisions?
So we are doing about the companion diagnostic only, sir. Now Signatera is here. So I think we should do what the data says, the lab which has been used.
Tumor-informed. I'm talking of tumor-informed, not just the lab.
No, but you have done the surgery, na?
No, you have done neoadjuvant.
So you have done the surgery, na? So you have done the surgery, so you have the surgical specimen, so you can get a tumor-informed decision, and you have the lab available, and if the affordability is not an issue, why not try that? Yes.
So tumor-informed ctDNAs are happening. Problem is we have to validate the level of detection. You know, the threshold of level of detection where it becomes positive versus negative. That validation can only happen after these local labs engage in clinical trials. We just cannot take analogy from another test and implement it.
So I think we should use the lab only
the
which has actually
companion
been used in
diagnostic.
doing, yes,
Correct.
in that.
So coming back to this patient, this is a second situation. So PT3, so probably these patients will be eligible for, because patient who did not receive any CT, so PT3-4 or node positive can be a case for Ambassador or a Checkmate 274. So either Nivo or Atizio, we can see, so they were benefited in terms of DFS. In Pembro, in Checkmate, so they had a PDL1 as a criteria, but in Ambassador, this was irrespective of a PDL1, and both of these were not statistically significant for OS. Now, Niagara and Checkmate 2.274, so now new approaches for an old problem, so maybe we can better select who to treat more intensively. So that is about the IMVigor moving from 01, 02, 11, and with Dr. Senthil will cover, so as Amish said. So however, exploratory analysis demonstrated that patient who tested ctDNA positive after cystectomy benefited from adjuvant atezolizumab, which patient who tested ctDNA negative. So now, coming to the third situation, so original, now the same patient again. So now you see the performance status is 2, so G8 is 11, grade 1 sensory neuropathy, creatinine clearance of 45, echo being normal, audiometry shows a moderate sensory neural hearing deafness. So now, Rishabh.
So this is very close to cisplatin ineligible. Most likely after seeing the patient, we would not give cisplatin. So EV plus Pembro is something which we would consider in this subset of patient.
Right. So, please.
Sir, EV causes significant neuropathy, and you have already mentioned audio, like
grade
sensory
1
neural hearing loss in a diabetic, long-standing diabetic patient, probably affecting other neurons, neuropathy also. So EV would be a challenge in this situation. So I would be a little reserved. I'll do the NCVs for neuropathy.
Then how do you,
if it is there,
so how are you going to treat this patient now?
If it is there, neuropathy is there, I'll not give the EV.
So what will you give? What are you going to give?
No, cochlear nerve is not a peripheral nerve. So cochlear hair cells nerve, no, they are not considered as peripheral nerve. So peripheral neuropathy is
in diabetic patient, if it is involved, that indicates you have already large vascular disease affecting the diabetes. That is what I'm saying.
No, practically you are right, but if you look at the trial eligibility
So we
criteria,
have to
taken
do the
peripheral
NCT
neuropathy.
and establish the neuropathy. That is what I'm saying.
So the major reason of discontinuation in EV was the diabetic complications actually.
Definitely, we have to rule out the comorbidities.
So last 3 minutes. So best suited for EV-303? Anybody? So Dr. Ramaswamy?
Patients who are platinum eligible as well as ineligible, sorry, and performance status is good.
So in this trial, even with because they have included up to PS2, somebody who is more than PS1 if you want to give systemic therapy, though it was a small population. Younger patients, normally you don't see such cancers. So younger patient, again, a small subset of patient, they have been benefited. So now there is a key, EV-304. So that is for from ineligible to an eligible patient of cisplatin. So perioperative already December 2025. So perioperative EV plus pembrolizumab extends survival in a cisplatin eligible MIBC. So now in one slide, systemic therapy options. If you see the NCCN 2026, so Vesper, OS benefit, but 40% discontinuance as compared to Gemcis. So for a Nivo and a Pembro, for those patients who have come to you after surgery, so Ambassador has shown a DFS benefit. Checkmate 274 also has a DFS benefit. And the Niagara, already EFS, OS, and a PCR, and EV-303, EFS, OS, and PCR. So without adjuvant treatment, 50% will recur, and recurrence for any cancer is poor, and that's true for urothelial cancers also.
Ghanashyam, do we have any comment for control arm of EV-303? It is actually just surgery. Is it acceptable is one thing which is there, and how many of us, although good results, how many of us would actually wait for the second interim analysis or just adopt EV-303 in their practice?
Sir, what I think is the control arm of EV-303 is justifiable because these are the population who are cisplatin ineligible. So by definition, if they are ineligible, there is very limited data available to use carboplatin in the adjuvant setting. Plus, I agree, Nivo has a data in the patients who did not receive chemo, the patients were included. That could be one argument, but we don't know which is better way. So I think control arm is still okay, not a standard of care.
Right. So the takeaway is the management of MIBC is the perfect example of the added value of a multidisciplinary approach to maximize patient benefit. All patients who are cisplatin eligible with more than equal to T2 MIBC should be considered for perioperative treatment according to the study results and receive platinum-based chemotherapy plus minus IO. Those patients who are cisplatin eligible upfront should be considered for clinical trials or upfront cystectomy or newer options like EV-303 and IMVigor011. So future standard of MIBC, so you diagnose, so you stage them, so neoadjuvant chemotherapy plus IO, undergo cystectomy, now you add ctDNA. If they are negative, so then probably no adjuvant treatment, positive, so you can put the patient on immunotherapy maintenance. So towards precision adjuvant therapy. And the last slide, the more I learn, the more I realize I don't know. So new data, new uncertainties. Do all patients need to be treated after surgery? So that probably ctDNA will answer. Do you have any means to select for patients most likely to relapse after surgery? Are there any particular patients population that might benefit as much or vice versa? And how are the new drugs being developed in the setting impact the perioperative scenario? So that was the last slide. So on time, Amish.
Out of 1,000 patients you have treated?
So my sense for someone who does not have neuropathy, the neuropathy actually begins to, and you can look up the data, starts to set in around cycle 5. For someone who has grade 1 neuropathy, up to cycle 3 is what you're able to give without dose reduction. Mostly that's the data. So for EV-303, most of your job is actually done by the cycle 3. And for the 4th cycle, one level dose reductions were seen from 1.25 to 1. So in essence, one can deliver for a peripheral neuropathy patient as long as they don't have grade 3 neuropathy to begin with. One can deliver the neoadjuvant treatment.
Thank you. I thank all the panelists. And I invite the second moderator, Dr. Tarini Prasad Sahoo. I don't think he needs an introduction, so I'm not going to do that. We have panelist Dr. Swaratika Mazumdar. Have I pronounced correctly now? Okay. नहीं, बाद में है ना? बाद में है. और डिस्कशन मैं ही हूँ. Dr. Stalin Bala. Stalin is there, yes. Dr. Ritu Jain, a dear friend. Ritu? There. Dr. Tarachand Gupta. Dr. Vamshi. Dr. Kshitij. Kshitij, yes. Dr. Savinay Ramji Digia. Yes, there they are. ठीक है? Okay, done.
Okay, sorry, I'll move on. So thank you, Dr. Amish, and thank you, Sendil Biswas, for giving me this panel. So I was tuned up for the Niagara one. So okay, so let's three interesting data sets. So we'll be discussing AMPLITUDE, CAPITELLO, and the PSMAADDITION. So we'll not be doing the keynote because these three will be the one prostate type, and I think this will make sense. And we have half an hour, so we will not be wasting time on it. So Dr. Vamsi, my first question to you, this is normally how we treat patients nowadays, but coming down, we'll go down to a topic, metastatic hormone-sensitive prostate cancer. So do you do NGS to look at the mutations at this point, or do you wait for the patient to become castrate resistant and then you do the mutations? So what's your practice as of now?
In practice, not doing it upfront.
Okay.
Typically, what we do suggest is at least get the germlines if they could be germline positive. Otherwise, advise regarding the NGS, but I usually do it sometime over the period, not immediately.
So later on you do it. Anyone practices to do NGS? No. Okay. So one more question. Ritu can take it, or Stalin. So if one intends to do a liquid biopsy, and really he wants to have a timeline that I will do a solid, but there could be a chance that you might not be there, and you want to send a liquid sample also, and you believe in the concept. So do you want to send it with the pre-ADTA, or you do a androgen deprivation and the solid comes negative, let's say after a month, that they could not have enough material to run the NGS? So at that point, if you send a liquid, will it make sense, or it doesn't matter? That's how we have done in lung cancer. So how should it be different in prostate? I hope you're getting the question of should you time a liquid biopsy in a metastatic hormone-sensitive prostate cancer if you intend to do so.
I don't have any ideas.
Okay, anyone can take it? Okay. So this is something which was interesting, and this was actually discussed in the ESMO, and this is something people have to remember as we start to do liquids. And the point is, once you do a ADT, and even if the tissue comes insufficient for an NGS on the blocks, in 2 to 3 weeks, the ctDNA really falls. And that sample would not be good enough. So if you intend to do, it's good to do a simultaneous, and the reflex testing could happen. And this is one of the data set which I pulled out, but this is which I thought should be there, because we normally send a liquid biopsy after we get a call that, okay, tissue wasn't sufficient. So for prostate, before you intend to start any treatment, if you do it, it would be nice. Okay, so this is something which I thought would be, I'll look into. Just to go into topic before, the liquid versus solid, you do not have any prospective validated data set which looks into the concordance in prostate as such. But if we look in the trials, how they're moving, I got the idea that everyone is moving to liquid nowadays. If you look at the TALAPRO 3, They have looked at liquid even for the HRD, which the AMPLITUDE and other trials did not. So basically the world is moving towards that. The only thing which I wanted was the timing of liquid sampling, and people here told that very rarely do that. Sevanti, you do liquid for every patient of yours, hormone sensitive?
So I do tissue,
Uh,
and then I do germline as well.
okay, so you send the liquid later on.
I send the liquid later.
Okay, so we should now. Okay, so we move on. Shitish, so does this anything mean to you before we go into topic? You have a SPOP or you have a P10 or you have HRR. So how do you look at when you see the report? So what pops up when you see the SPOP or SPOP, however you call it? Let's speak of this first.
Right. When we see the report, I think it is important to understand HRR is a heterologous.
So I'm just going to speak to you for SPOP, the SPOP. If you have it, does anything strike to you? Or any other panel can take this?
No idea.
Okay. So, this is something not a random, not a prospective. So important is when you look at it, you are more convinced that the ARPIs would work better. So this is what it really means to, and this has some meaning when I come into the data set. I'm just building up for how this trial would be looked into. The speckled, S is for speckled, and then there's something. Okay, you can Google. See, so I remember the speckled one. Yeah, speckled. S is for speckled, the rest I don't know. There's something. So, Tara, P10. So how do you look at P10? Do you feel happy? Do you okay, the patient might not do good? What do you feel through as a prognostic marker for P10? Loss of P10?
Whenever we find any target in the tumor, we usually get happy that we will be able to target the patient with the medicine.
So P10, anyway, you cannot target as of now. You don't have the drug. So are you happy?
Then we may wait for the launch of the drug.
Anyone wants to do it?
So I think biology is
so basically I wanted to put that forward. The biology is bad. The patients are going to do normally poorer, and if you get that mutation, and we'll see how the trials have looked into this. If you look at the BRCA again, if you look at the control arm when I come to the trials, and normally how the non-BRCA patients would do and how a BRCA would do, you see that they do poorly if not targeted. So that is also something that people need to remember, that these are prognostic, and to some extent this could be predictive, and these two also are starting to get predictive. Yeah, please.
If I am planning PEACE or Arasense in the patient,
yeah,
triplet therapy, and Sevanti's patient comes to me for second opinion with all these, do I not give them, or do I still see, like for example,
do you not give them the triplet?
I have decided triplet therapy and patient comes with P10 or SPOP, whatever that may be. Do I not give them triplet is a question today.
So first thing, you didn't attend the debate which we did in AIMS. So bad, Amish. so point very quickly away from topic, but I'll answer that. So as of date, a triplet is for some patients, the high volume and others. The problem with triplet is we have compared it along with only the chemo standard. The ARPI plus ADT looks to be much more powerful as a combination than the DOSI plus the other. So that will, the two trials are ongoing. One of them, Aspire, I think I got the name right, will come up, which will prove that the triplet versus ARPI plus the ADT, is it superior the triplet? So at this point, if this prognostic factor, if I look at P10, if it is there, I'll go to something that is chemo-based. I'll go to something that's chemo-based. I will probably not do the ARPI. I'll probably at this point go to the triplet versus the DOSI plus the combination, however you look at it. Let's see the CAPITELLO and see if you are convinced about changing it. Okay, so this is the P10 AKT pathway. Why it is important? Basically, if there's a loss of P10, this pathway gets very active, apart from the AR receptor pathway. So basically, there are two pathways which is there, and once this is inactive, the pathway goes for a free run. And that is how I can tell it. Now look at the CAPITELLO, and here the panel, I would like to indulge the panel here. I think Swaratika, you can come in here. I just wanted to look at this first, the combination of the placebo and the abiraterone ADT for a patient on the CAPITELLO, which had predominantly high volume and were high glycine score. So these patients, majority of this trial had high volume and high glycine score, so basically high risk patients.
Yeah.
So are you happy with this, that they did have only abiraterone ADT, and are you okay, and would you like to know that why a triplet was not there? So my question is the standard arm weak to what you normally would practice?
Yeah, so I think this fact was acknowledged even by the authors that 60%, almost 55% were high-risk disease and they were heavy burden disease, and yet the standard of arm did not include docetaxel because at the time when the trial was conceived, triplet therapy was not the standard of care. And they've acknowledged that. In all fairness, they've acknowledged it.
So this is one issue. Or let's
so
say
it is definitely a weak standard of arm. There's no contest in that.
Okay. So anyone fans of apalutamide as ARPIs here? Okay. So any concerns if I change this to apalutamide? Or if I change this to, let's say, enzalutamide? A lot of us use enzalutamide.
Drug interactions.
So here something is very important, that they chose it for a reason. The abiraterone was chosen for a reason. The apalutamide and the enzalutamide, if it is done, they have a drug-drug interaction, and apart from that, the cytochrome is activated, which can lead to the capivasertib to be lost out very quickly, so the efficacy might be lost. So whenever you use this, and if someone is convinced of this data set, make sure the ARPI partner is very clearly abiraterone, and just you cannot use it as you like with any partner. So this is something that should be a take home for all of us. Okay. So this was a double blind, and the PTEN deficiency, Vamsi, are you satisfied with the less than 10, because there is data set to tell us that absolute complete loss is much better versus maybe 99, 95. So why do you think this 90% was taken?
So they have given some explanation that 90% would cover, but I'm more surprised why they didn't do it with NGS. I mean, if every other study has done with NGS.
We will come to that.
So that was my bigger argument.
So are you happy with the 90%?
I mean, it's something like a PDL1. More the merrier, less the worse. So they have taken a cutoff, and I think you'll show that data that more improved better.
Ritu, any thing you want to say on the 90% thing?
No, I also was wondering why they didn't do NGS, just why they went by
I'll come to that. It's well explained why they didn't do NGS, and actually NGS is still not a standard, so they are very much justified, and this is much easier to do it. I'll come to that. I have a question on that. Okay. So this is something that people remember. Remember this data set, 97% had a valid IHC report of the 6,200 patients. So this IHC is easy. You have a 97% who were positive or had a report which was okay and which was as per the standard. And of this 97%, with the cutoff of 90%, 25% were PTEN deficient. So only 10% or something had a staining. Otherwise, that is something. So this 2-3 things are very, very important here. The primary endpoint was radiological PFS. Anyone in the panel wants to, is it okay to do a radiological PFS for, because all the prostate cancer trials which you see, the refractory or maybe the sensitive setting metastatic, the RPFS is the primary endpoint for all that, like IDFS is for adjuvant breast cancer. Any concerns? Anyone in the panel?
OS would be better, sir, but for the RPF is also a valid endpoint.
Okay.
But if at all the benefit is more.
So what is the cutoff benefit you're looking at? Hazards of 0.7, 0.3, 0.2?
Anything less than 0.6 or so.
Any data to back it up? Any reference of that 0.6? No. Okay. Dr. Sendil, anything on radiological PFS? Yes, we agree.
It's a very well accepted surrogate in CRPC. There's good data in HSPC also, but it's not as strong as you get in CRPC. So it's an accepted surrogate.
So point.
Again, I have, from day one, the first trial which had RPFS as a primary endpoint, I have an issue in HSPC. CRPC fair enough. In fact, the primary endpoint in all now new HSPC should be time taken to CRPC, because we all know the quality of life once you achieve CRPC is very bad. And that is what the PEACE and Arasens also showed, and it was very, very statistically significant. My point is radiological PFS. मतलब एक दो lesion हड्डी में बढ़ गया and you change the treatment.
So I agree with you, Amish, that हड्डी में बढ़ गया तो it doesn't matter. So the point is that when you're doing a trial for a regulator, you have to show something that is a well-validated surrogate for overall survival.
Yes.
So that's why they will do like that.
So,
Your
Dr.
point
Sahoo.
will definitely be one of the other endpoints
Quickly,
they're trying
we
to
have two
measure.
more trials.
So it
Yeah.
is there.
Sir,
No,
how
so-
many times? How many times we are doing PSMA PET or any radiological
So again,
other than PSA,
so-
which is
so
declining?
I think what everyone should go back and read what is RPFS.
Yes.
In this RPFS, they don't just use scanning alone. There's a very clear, it's a nice definition. It's done by the PWCG group, and what they have said is you have just 2 naye haddi, they will not call it a progression. They will wait for 4 weeks, repeat a scan, you get 2 more haddi, then only you call it a progression.
Yeah.
Right? So that's a very clear definition which I have given.
So it has a robust background. So that's why I put this point forward that RPFS in prostate is as good as we look at IDFS for early breast cancer. So this is something people have to remember, and there is a history behind it. So is it practice changing? Capitello, right from there to this side, please. Quickly, yes, no. Who is yes? Who is yes? Result slide. Okay. So I think it was discussed, as he told it. Okay. So I'll tell you the result. I have it. Not at all. Okay. So anyone in the, because you had access to the paper. All of us had actually access to the paper. So Capitello, is it a positive trial? Would you think it's practice changing? If no, why? Yes.
Positive trial, sir.
Yeah, it is positive.
RPFS benefit seems convincing, but only problem is the toxicity, the number of adverse events, and
so for you, you look
the more of
inclined
toxicity
towards the
So
Capitello.
not only here, everywhere the PI3K pathway where we targeted, we burnt our fingers.
Kshitij, you're thinking something, yeah.
So practice changing, yes.
Okay.
Because obviously there is a novel agent which is targetable, number one. The problem is the magnitude of the benefit. The hazard ratio is 0.81.
Okay.
That is number one. Number two, I am concerned about the toxicity.
Yes.
Number three, I am concerned about the reporting for P10 by IHC, because there can be a lot of variability amongst the pathologists regarding the P10 reporting.
Okay.
So that is
So you have few concerns, but you still believe it's a positive, and if given a chance, you will change your practice. Perfect.
Yes.
Fine.
In some patients,
How? I'll come down to the next question.
Yes. How will choose a patient? So I will.
I'll come to that. Anyone?
Sir, I have something. Sir, if a patient comes to me with a report and that shows P10 deficient, and at present the patient is CSPC, and I have this trial data, there is some benefit of capivasertib, but the same drug in CRPC setting has failed. So that sort of thing I have to, if I don't use the drug right now, I won't be able to use it.
Okay, that is why you want to do it. So
I can consider it.
Okay. So I'll come to that. So basically, this is what I was speaking of. This is that indirect data set from one more thing. They're telling you that if E10 is active, you have normally inactive. You have normally a high decipher, and this is where the docetaxels are more active. So this is the indirect way of looking at P10s. So NGS versus IHC, this was put up, and Vamsi has a big problem, and Ritu also has a big problem with this part of it. So telling you NGS is still not a standard. Can you just maybe qualify your statement, anyone, both of you? Why do you think you are so much worried about this NGS? I will put in contrary. If you look at the trial which was in castrate resistant, which looked at the one of the same pathway, if you look at the NGS, only 67% of the samples could actually qualify to have an adequate NGS. So you are looking at a method which is not going to, you are going to miss out on a lot of patients. A lot of patients will not qualify. So why do you think NGS not being a entry point was a criteria?
The only thing, Tarini, my thing is about the standardization of IHC.
It is
It's
standardized.
more of technical rather than data is convincing. We started off with HER2 like that only, IHC.
So IHC is well standardized, and the initial
P10.
Yeah, for P10. And if you look at the things, this is the data set. So I'll tell you my little take on it. So this is actually intended to have a hazards of 0.7. when this trial, the statistical design was met. So ultimately came up to a hazards of 0.81 as was spoken by the panel. This is something interesting. I want quickly people to remember. Look at the RPFS Kaplan-Meier and look at the time to PSA progression Kaplan-Meier. This was the endpoint. And if you can make up the time to PSA progression happens faster and earlier than the radiology PSA. So point here is these patients will relapse early and then the PSA will start increasing. So, sorry, I knew when I told. So point here which I wanted to make is, do we then go on doing the radiology looking for the RPFS, because the standard practice is to do a PSA when it increases in a asymptomatic patient, then to do it. But here it is little contrary, so this is also a flaw, something we have to decide, because here the PSA, this data tells you, rises later than the radiological progression. So this I don't have an answer, but this is something I thought is very important for people to look into the data set. This is the trial which is in the hormone castrate resistant and the ipatasertib, and this trial is the IPA potential 150 trial. This trial just had a cutoff of P10 of 50%, but here it is 90%. And what really happens is, if you look at it, the higher the P10 IHC loss is there, it correlates nicely with the NGS. It's actually around 90% or more. The concordance in the 90% or more loss is actually concurrent with the NGS. So that is what I wanted to tell you. So it's pretty okay and pretty done actually. Okay. So I'll just skip over just to tell you one last thing. I asked for this article. There were a few nice comments on it. So this article is something people should read, just to thought process, that we just take 1 or 2 biopsies of prostate. Is it good enough to run a NGS and get the sample? This tells you no. You should get more number of cores and then have a DNA where the chances of you getting the positive mutation is higher. And they have looked at, and this paper tells you probably 4 to 5 cores is something they look is adequate. Something like the endoscopy number of biopsies for gastric cancer is around 7 to 8 for IHC for HER2/neu. So this is again something maybe we have to look into and change our practice if we are going to do the NGS part of it. Okay. So shifting gears, amplitude. Vamsi, you know the data. It is a positive trial. Will you change practice? For me, Capitello, I'll wait. I'll still wait.
So I think I'll stick, if at all, if I do this, I'll do this to the approval criteria. That is only the BRCA2. I wouldn't do the whole.
So you will do only the BRCA1, BRCA2. You also won't do it for the effectors one. So you will not do it. Okay. Because this patient, this is a trial which is positive for for the intent to treat also. And these are the Kaplan-Meier curves. This is the BRCA positive 1 and 2. 2 is more common in prostate. The hazards is a staggering 0.52, again a RPFS. If you just include, along with the BRCA, you include the BRIP, the PALB and the RADS, then it falls from 0.5 to approximately 0.57. And if you take the other 2, 3, they have told the CDKs, then it falls to around 0.63. So basically, the benefit is most with the BRCA.
So it's something like a PDL1. A PDL1 more than 50 drives the entire subset.
So
that's what happens.
So the question to for you is, why did you tell you are only convinced for BRCA?
So
Look at the PFS curves here.
No, that PFS curves you're showing include the BRCA.
Yeah.
So I want the data for non-BRCA.
So I think there is a supplementary which shows non-BRCA, it is just the hazard ratio is, I think it's not significant. It is 0.8 or something like that.
Okay. They were not powered for it. They were not powered. I'll tell you very clearly.
It's a hierarchy design and it was not.
No. Yes. So basically this trial was powered to look at 2 sets. One was the BRCA, that is the A, and the B was the BRCA plus the effector. It was not powered to look at anything beyond that as a subgroup analysis. So this is how the statistical design really goes. And if you look at it, nearly everyone benefits, except if someone wants to look into this and tell the high Gleason score does not. That is a different thing. This is what my panelists are speaking about, that if someone does not have a BRCA, then this is what they are speaking about. The hazards is 0.81. This is an exploratory analysis. So you have to take with that pinch of salt. But yes, they are pointing towards this, that the hazards fall from 0.52 to 0.81. So basically, it's again driven by BRCA. That much we can always tell.
So Dr. Sahoo, if I'm not mistaken, around 60% were BRCA and the rest were non-BRCA,
50-50.
50-50 almost.
50-50.
So that 50 is not a small number.
Yeah, it's not a small
It's
number.
not a small, it's not like our 57. That's
50,
something there.
nearly
But it's not a
50.
small number at all.
Yeah.
So you can't say there were 8 of them, so each was only 2%, therefore
I know,
I'll ignore
but
it.
because it is not powered and we have been taught.
Then don't include everything.
Okay, so this is something that surprises. I would like to take the help of the panel myself. We can look at the quality of life index, these scores. And if you look at it, there is a decrease in in all factors to pain, the progression, the time to progression, time to pain relief, everything is nice. Somehow the quality of life is nearly around that what is there with the standard arm. So is it because of the toxicity with the drug? That is something which I thought that has to do with that. I'm not sure, but this is something people have to remember. The OS is not mature. It is still maturing, but yes, the curves have started to separate. I do not know what the maturity will be. Any concerns? It's a positive, one of the best hazards of all the 3 trials we are speaking. Anyone? So, any concerns about this regimen?
As an, I mean, the concern is with any PARP inhibitor. One is the follow-up has not been long enough to, look at MDS and
the other
AML
toxins.
events.
So important is, this is a toxic drug. All of us have used a PARP. It's not going to be easy. So be careful about it. The dropouts were there and more towards this experimental arm. So, and the long-term toxicity, we still do not know. There was only 1 MDS reported in this trial as of date. And so that people have to remember. So last 5 minutes, we'll go to something again, a positive trial. A PSMA addition, randomized phase 3 trial of the 177 lutetium PSMA. This was again the same thing, hormone sensitive. This patient should have at least 1 metastatic lesion on the gallium, and then it should be appropriate for the ADT ARPI. And all the 3 trials had high risk, high volume as the most of the patients. So basically all the patients were majorly high risk, so that criticism will stand on for all the data sets. But here it was, they took everything. So they did not have a criteria that BRCAs are taken out, the P10s are taken out. This was all comers who at least had a 1 spot which was there on the gallium. So this is a data set which was ADT plus ARPI, how we normally do, versus adding the lutetium. So this is it, and you could go up to maximum 6 cycles. So clearly, questions. Anyone? Stalin, you have been quiet, and then Ritu. Would you recommend early use of lutetium PSMA because this is a positive data set and looks good, the curves separate out nicely? So what is your take on it? Do you have concerns about it? Or would you like to wait later on for a use of lutetium after progression in the refractory?
This data seems promising, sir.
Okay.
So the improvement.
Okay.
So, and I am a fan of lutetium PSMA therapy in prostate, especially I had seen good responses in CRPC setting.
CRPC.
So whether I will move it to is one thing is 2 factors. One is the cost of the therapy, so it increases use. So keeping aside, so if you start using it in metastatic HSPC, I don't think the lutetium will be sufficient to use.
So you are okay with it, Ritu?
I'm okay with that. Its use.
I'm also okay with it because in metastatic setting, good response. And
so you are also okay with this?
Yes.
Bamsi?
No, not okay.
Not okay.
Not okay.
Not okay. Any reason?
Again, see, you have to give 6 cycles, and I don't think you can just say there is no side effects. In this trial itself, 20%, 30% side effects were there. Okay. It's not as simple to use.
Apart from that?
Apart from that, they have used it only some lesions should be gallium positive, they have said. Okay. I mean, I'm not sure it's a very heterogeneous thing which they have combined together. So I'm not very convinced with the data.
So this is something which came up from the discussion slide in the ESMO. I borrowed it from there. And this is something that really adds logic, and it was told that that a percentage of patient here actually could cross over. This was allowed in the trials, and that's allowed in all lutetium trials. If you look at the crossover is inbuilt in the trials. And if you look at it, the PSMA 4, again, these are all the patients who were in the refractory. There was a RPFS, and suddenly when the crossover here, it was approximately 90% crossover happened. Nearly everyone crossed over. In the standard arm to a lutetium, the OS suddenly goes away. The second data set which really is interesting is again the PR21, again in the refractive setting. Here, the crossover was 50-55%. But here one interesting thing happened, the OS benefit was there, and refractive setting, the sequence of docetaxel followed by lutetium is giving the OS benefit with a 55% crossover. So the question here is, will the PSMA addition trial, when the crossover is there in nearly all the patients to 90%, will it be a OS positive data set, or can we remain with the lutetium and reserve it for the refractive setting? This is something that people have to remember, and there is a precedence to this effect, and this is the two things which I wanted to show you. So can we optimize? And because let's say I have a uptake which is SUV more than 10, or I have a SUV which is 3. So would you be okay doing it?
So I don't think so. It will be decided based on the SUV value. There are so many other things in the platter in HSPC setting.
So what I'm trying to tell is, can we start choosing? Because if you look at the therapy trial, again, and what happened in the trial, interesting, I have a slide on it before I end. If the SUV of more than 10 were the patient who did the best. So my point is, can we start choosing? Nothing that you cannot do it. It's anyway all comers. So
Sahoo, site of metastasis could also be one of the confounder for this type of trial.
It did not matter actually. Everything was good. So that's why I told, can we? So it is actually good for everyone. The only concern was the crossover which I told. And could we do with lesser cycles? Because 6 cycles are mandatory. If a patient achieves a CR, radiological, after 3 cycles, can we stop it? So that is something we need to do. Last was toxicity. Vamsi spoke about it, but the toxicity which people are really concerned about is the second cancers. The second cancers actually were doubled. Numbers small. So in the longer follow-up, I do not know what is going to happen. So this is something people have to remember, that long follow-up. Last slide, I'm over. And this is what I'm speaking about the therapy. Just look at the quaternary 4, and if the SUV is very high versus when the SUV is low, you see a difference in the response rate. So probably this is how probably you can choose it. I do not know the right answer. I would like to listen to others. So this is where I'll stop. And my take home is, NGS at baseline in metastatic hormone-sensitive prostate cancer will be the future. That's my thinking on it. And please, if you want to send a liquid, send it before you even initiate androgen deprivation therapy. The CAPITELLO 281 for the quantum of benefit, and it did perform lesser than what it was. I think I will hold on till that, looking at what was discussed. Probably absolute P10 loss would be the best. The hazards actually is the best actually for the absolute, but it's a very small difference. IHC versus NGS, we will move to NGS. That's no doubt about it, but this is something that is an evolving phase. The amplitude, PARP inhibitors, at least in BRCA1 positive, would like to add, but yes, this trial was not powered to answer only BRCA, that we spoke about it. OS benefit will be the icing on the cake for me. That is what I really want to look into. In this, the PMS addition, for me, I speak for myself, we'll wait for further data. The crossover data is very interesting. If it does not, then gives us a second chance to do it at progression. Long-term toxicity, and this is, people have to remember, the toxicity of these things can be very bad. Second cancers, doubling numbers, those small, very short follow-up is something that I feel will be important. So anyone wants to pick up anything which we didn't discuss? Okay, so yeah. SPOP, yeah.
Gene, and the mutation in SPOP actually helps stabilize AR and other markers that makes these patients respond better to ADT. There's a lot of detail to the hotspots of these mutations. These are not frontline, but most of our comprehensive genomic profiles cover.
Yeah, so if you do it, be little more confident about doing the dual even with ARPI. That's what I meant to. Thank you. Thank you.
Thank you, Tarini. And I must say, which Parekh sir and me, we have been struggling with since a long time. I think all the panelists are very well read. up till now, and some of them I could see is also have read supplement and come. So I'm very happy about that. I think that is what we wanted, and I would try to save some time because 6 papers Tarini has summarized well. I agree with all that. So Niagara, according to me, is practice changing. Wherever patient is eligible, I think we can start doing that in our practice. EV-303, 57% PAT CR, unheard of, amazing. The only thing, as Senthil pointed out, do we next move to organ preservation? Because radical cystectomy, I believe, is too strong a surgery which we can do. But as of now, cisplatin ineligible patient, early OS separation also we have seen. So in case of cisplatin ineligible, if patient is either not fit for radical cystectomy, not ready for radical cystectomy, or can afford both the drugs are available in India, they can afford, I think it's a good point to make. IMVigor, I am not confident of tumor-informed ctDNA as of today in India. Will be too far-fetched for us to go for IMVigor011 at least. Coming to PSMAADDITION, early data onset is positive. I still am worried, as Tarini mentioned, about long-term implications of lutetium. These HSPC patients are now living for 6 years, 7 years, 8 years. And if you give them lutetium upfront, and I have seen at least 2 patients whose neutropenia did not recover after 6 to 8 weeks also. So I personally think that PSMAADDITION, although positive, still needs some consideration about it. I would want some subset analysis, SUV more than 10 is, मेरे PSMA PET scan में SUV हमेशा 40-50 ही होता है, तो I don't know more than 10 का क्या significance है, you know, that is what we see in Delhi. But I need some subset analysis before I can adopt PSMAADDITION. Amplitude, I'm very impressed. BRCA1 positive subset में it is actually a good data. The only thing is, when you have a high volume disease, as of today, triplet practice करना है या BRCA1, BRCA2 में do we add PARP inhibitor? Answer, I don't know, but I was highly impressed with BRCA1, BRCA2 subset, and that is something I believe will change the practice in future, if not today. CAPITELLO definitely is not practice changing as of now. OS, I will wait for OS about that, and with that, I think I have saved 7 minutes of the topic. We will move beyond. Sorry? We have 7 minutes. Okay.
Problem because it's unlike the breast utilization of capivasertib, where you don't have a companion hormone that requires steroid. So had this been good with ENZA, APA, that would have been a slightly different setting because the hyperglycemia is a reality.
Right. So I always hate to disagree with Dr. Sevanti, but I disagree here because 5 mg BD prednisolone in my practice is not an issue much of
with
10
capivasertib.
mg BD. I agree, but we give abiraterone every day, Shefali.
That's
and
not the point.
capivasertib addition to that hyperglycemia. I don't have too much of experience, but my point is abiraterone with prednisolone is not much issue.
Absolutely. It's just that capivasertib actually, just like all PIK3CA pathway inhibitors, it will increase. I actually
correct.
just almost lost a patient with...
almost?
Almost.
Okay.
A very, very aware patient who just thought that her diabetes need not no longer needed to be controlled
So,
and was on
Sevanti, I got your
capivasertib.
point. My point is that capivasertib minus capivasertib plus enza,
Yeah.
it will still have an issue of hyperglycemia.
It will.
That is what
It's
I'm
just
saying.
when you have the steroid, it will
absolutely, I agree on that point.